thank you very much for the introduction. Good afternoon, everybody. We've all had a very substantial lunch, so I hope that I can keep you awake. My name's Elaine Boyle. I'm a neonatologist in Leicester in the UK. Thank you very much for the invitation to be here in Lisbon. It's apart from the weather, it's been wonderful. So can everybody hear me, first of all? Or stick your hand up if you can't. Okay, good. Okay, so we'll start off with a question. What 3 words come to your mind when you think of late preterm and early term babies? And if you can't think of 3 words, don't worry, just write 1 or 2 down. Whoops. That's interesting, not always trustworthy. Stable. Beware, underestimated, I like that. Dodgy. So really nice things coming through here that I think reflect my own views, but not everybody's. Okay, so that's really interesting to see where what our starting point is, I think, and what we all think about these babies. Always very stupid. Less medical problems, respiratory distress, not enough attention, more family involvement. Oh, those are some really interesting and perceptive, but above all, what seems to be coming through is underestimated. And I think that's a fair comment. So over the next half hour or so, I'm going to be talking to you a bit about the concept of prematurity and where we are with that now, the impact of these babies that we're going to be talking about, a bit about the short-term challenges, the neonatal challenges that we have, but also the ongoing challenges that are associated with birth at late preterm and early term gestation. And what might that mean for neonatal practice and indeed medical practice in adulthood as well? So on your left, on the left of the screen, you see Henry, a lovely, big, well-term baby. He was born at a mature gestation, and this is how we think of term babies, full-term babies. Big babies, mature babies, well babies, and generally they have good outcomes. In contrast, when we think of preterm birth, I think because of the population that we look after and that takes most of our time, we think of them as small, immature, fragile, very sick, and often, sadly, with poor outcomes. But what about this baby? And these babies? And this baby? So babies like this, they're not very tiny. They're not really very sick when we have them in the neonatal unit or on the postnatal ward. They may not even be preterm, but nevertheless, these babies are not fully mature and they're not completely well. You can see 1 on respiratory support, 1 with a nasogastric tube, 1 looking a little bit yellow. But these babies, these more mature babies, used to be the sickest babies that were looked after by neonatologists. This is a newspaper cutting. And my question is, who is this newspaper article from the 1960s talking about? You want to see it again? The baby that was born at 34 weeks gestation in the 60s. somebody has a sense of humor. Thank you for that. And another person with a sense of humor. So yes, what's coming through, I think many of you will recognize that this was the son of John F. Kennedy, born at 34 weeks gestation. Patrick Bouvier Kennedy had severe respiratory distress syndrome and sadly died at 3 days of age of that respiratory disease. So these were the sickest of the babies, and these were the babies that didn't survive. But things have changed. Things have changed a huge amount over the years. And we think about gestational age differently now. You'll see along the top of that diagram, a dichotomy there, preterm, anything between 37 weeks, and term, any baby born above 37 weeks. But I think now we're understanding that there's much more of a continuum, and there are all shades of babies in this continuum. It's much more complex, much more nuanced than we had previously thought, and certainly not a dichotomy of just preterm and term birth. So the babies we're looking at are these babies in this sort of lilac region, the moderately preterm and late preterm babies born at late preterm and early term babies born at 34 to 38 weeks of gestation. Why are we interested in them? Well, this is data from England and Wales showing the births for 2021 in each of these gestational age categories. And I think you'll see that although the amount of time in our neonatal units and the amount of funding and energy that goes into looking after the extremely preterm and very preterm babies is extremely high, the numbers of these babies are very low. But in contrast, the late preterm and early term babies are an enormous group of babies. And if for nothing else, they're important for that reason. So late preterm births account for almost 3/4 of all premature births, and late preterm and early term births together account for around 40% of all babies that are born. So what do we know about their outcomes? So these babies, when we meet them on the postnatal ward or in the neonatal unit, they're often well grown. Many of them don't darken the doors of the neonatal unit. Many of them don't require specialist neonatal care of any kind. If they do have morbidities, they tend to be relatively mild. They are often, in many units, managed much as term babies are, as full-term babies are. They tend not to have very long hospital stays, though possibly a little longer than a full-term baby. And for the most part, these babies are not followed up unless they have been particularly sick during the neonatal period. But if you take a closer look at these, you will recognize this constellation of issues that these babies have and resulting from their immaturity. And it's a bit of a vicious circle. These babies are sleepy, they're a little bit sluggish. They tend to get cold. They tend not to feed very well. They tend to drop their sugars. They get jaundiced. They become sleepier. So minor morbidities are very, very common in this group. They're mostly related to poor feeding, metabolic immaturity, as you see in that diagram. And around 30 to 40% of them do require some sort of specialist input, whether that be care on a neonatal unit or additional support on a normal postnatal ward. And of course, we've been hearing about infection screening, and these will make up many of those babies that get infection screens. And the yield for infection will be low, but we get uneasy about them because they have all these sorts of problems. They don't tend to breastfeed very well, and breastfeeding rates at discharge are low. And they do tend to bounce back into hospital, either to the ED department or as an inpatient within the first few weeks of life. So as far as breastfeeding is concerned, the late preterm babies have really significant challenges, and that comes through in pretty much all the studies, and it's probably related to a number of different factors. So there are maternal factors, mums that may not be very well, they may have complications following delivery, there may be social factors involved. Add to that a baby that's not completely mature, and you have a likelihood of that baby not breastfeeding unless there is a lot of hospital support, which is another issue, I think, because many hospitals simply don't have the resources to be able to support all of these very large number of babies. Another study has also shown that early term birth is associated with not breastfeeding at hospital discharge, though the evidence for that is less compelling. So jaundice is another problem that these babies have, and you can see that that persists up to about 14 days, so that if these babies are discharged early, they do tend to come back, and many of the babies that do come back into hospital, it's because of jaundice. So the commonest reason for neonatal unit admission for these babies is actually respiratory distress. That's being admitted to a neonatal unit. And although intuitively we think of respiratory distress syndrome as the problem of the very preterm babies, it's also the most common diagnosis in this group of babies. And the respiratory illness can be quite severe, and they can require ventilation, as you will know. And really, there is no consensus regarding the management of these babies and how best to treat their respiratory distress. Do we just let them get on with it and get over it, or do we become more active in the management of these babies? But the potential for respiratory illness goes beyond the neonatal period and beyond that initial respiratory distress. So this is looking at admissions to neonatal units for late preterm and term infants for RSV bronchiolitis, and you can see that they are compared with the reference group of full-term babies. These late preterm and early term babies are much more likely to be admitted for RSV bronchiolitis. So does it go further than the first few weeks of life? So this is a study looking at some nationally representative data from the UK, which is looking at hospitalisation, and that is greater than 3 admissions, firstly between birth and 9 months of age on the top, and secondly from 9 months to 5 years of age. And what you can see if you look across the highlighted section is that the reference group of 39 to 41 week babies is there on the right. And you can see that the risk, the odds of having more than 3 hospital admissions is by far the greatest in the smallest of the groups, but it's still increased even in those born at 37 to 38 weeks. And what you can see is a gradient of risk there, and that is there both in the up to 9 months and between 9 months and 5 years. So this increased risk of illness does seem to persist into childhood. Importantly, though, this is looking at the same data, but highlighting the population attributable fraction. So this is the impact in terms of the population. So the numbers influence that, the numbers of these babies that are affected. And you can see that the 34 to 36 week group and the 37 to 38 week groups, both at 9 months and at 5 years, the impact is greater in those groups than it is in the less than 32 weeks. So by the fact that there are many more of them, they are likely to exert more of an impact. So this is just looking at it in graphical form. You can see that this is looking by gestational age, and the different colors represent different gestations. And this is looking from birth up to 7 to 10 years. And you can see that there is still a measurable, albeit smaller difference at 7 to 10 years between those babies born at 34 to 36 weeks, shown in blue, and the green group in of full-term babies. So this propensity for being admitted to hospital exists even when you get older. What are these admissions all about? And I think this is really quite clear that the top line there, which is a sort of a lilac line, represents infection. And again, looking from birth to 6 years of age, infection seems to be the primary reason why why children born at 34 to 36 weeks are admitted to hospital. And again, you can see this gradient of risk, which persists right up to 37 to 38 weeks in comparison with the full-term reference group. What sort of infections do they have? Well, they seem to be respiratory infections that dominate, both upper respiratory infections and lower respiratory infections. There's less of a difference by the time you get to later childhood with other viral infections. But again, a gradient of risk with the lines not quite meeting with the full-term reference group. So that's early childhood. What about later childhood? So this is data looking at long-term respiratory outcomes in early term babies. And this is a systematic review that I think very clearly shows that there's an increased risk of childhood respiratory morbidity for these early term babies when compared to the full-term reference group. Obesity and overweight is something which is plaguing our society now, certainly in the Western world. And it's not clear why that is. Some would say it's sedentary lifestyle, some would say diet, and there are clearly multiple factors. But there is a signal in many of the studies looking at late preterm and early term babies that obesity and overweight may be more prominent, particularly in late preterm children. Early term, the evidence is less compelling, but some studies would suggest that that obesity and overweight are more likely in the early term group as well. So let's think about later development for these babies. So this is a study that's looking at early term, late preterm, and moderately preterm, so 32 to 33 weeks. And you can see that on all the levels of the ages and stages questionnaire, there is a measurable difference, a significant difference between the late preterm and the full-term reference group. And for gross motor, there's a difference with the early term group, though less convincing for the other domains. But there does seem to be a measurable effect on development. This is looking at school readiness, numeracy, English skills, cognitive ability. And again, this is a British study looking at the Bracken School Readiness Assessment, British Ability Score, and you can see again and again that gradient of risk between being born at the highest risk between 23 and 31 weeks and the lowest risk at 39 to 41. And that, again, the up to 7 years, there's still a difference even at early term. So this is a recent systematic review looking at multiple dimensions of development, and many of the studies lump the moderate and late preterm groups together. So you'll see that in green, it's highlighted the 32 to 36 week groups, and in yellow is the 34 to 36 weeks, and the light grey is the early term group. And we have the term reference group in dark grey. And for many, many of these domains, you can see that there is a gradient of risk there as well. Seems to be most marked in developmental coordination disorder and in socio-emotional behaviour scores. But there is a suggestion there that there is a worse educational achievement, which may persist right up until the end of school, and also in association with an increased risk for special educational needs. And this is coming out in many studies, that there is an effect seen at school age. So let's look a bit more at that. So this, again, is some work from the UK Millennium Cohort Study. And what this is looking at on the vertical scale is the probability of not reaching the expected learning and achievement within the class at school. And what this shows is the age within the class, so whether the child is born at the is one of the oldest in the year or the youngest in the year, whether the mother has good qualifications, lower qualifications, or high qualifications, so the mum's educational status, and whether the child is a boy or a girl. And what you can see is that if you're young in your class, your mother has poor educational attainment, and you're a boy, you're likely to do much worse at any gestational age, but the difference is still there even at 37 to 38 weeks gestation at birth. And this is just showing the same, really, that at primary school and secondary school age, there's a measurable difference in primary school age between the 34 to 36 and 37 to 38 week groups, particularly in English and mathematics. But it seems to be attenuated by the time they reach secondary school. So that these children seem to catch up somehow, but they haven't caught up by the time they start school. So birth before full term does seem to be a risk factor for poorer performance at primary school, with the late preterm babies having a 20% higher risk of not getting the levels of attainment that they would be expected to. But by the time they reach the end of compulsory education, so 17, 18 years of age, 16 to 18, these differences are only evident in the 32 weeks group and below. Another group have looked into this in more detail and wondered whether this is related to whether the children have other problems, health problems. And you can see that there's differences there between the gestational age groups, again, a gradient of risk, but that the risk seems to be higher in those that have got any chronic condition particularly, but also cardiovascular, respiratory, metabolic, and neurological problems seem to exert an independent influence on whether these children have attained the level they would expect at school. And these are chronic conditions that have been diagnosed by the time they get to 2 years. So we're not talking about late diagnosis, we're talking about early diagnosis of chronic conditions, maybe some of them in the neonatal period. So the studies are consistent in showing that late preterm birth is important and that the effects may attenuate with age. The evidence for the adverse effects of early term birth, I think, is very conflicting. But the greatest risk may be related to health problems. So what about adulthood? How do these children fare in adulthood? Well, this is some Swedish data which looked at babies born between 1973 and 1997. And it's looking at the prevalence of survival without major morbidities. So you can see that there's a small difference even between the 37 and 38 week groups, and a more marked difference between 34 to 36 and the full term group. What are these problems that they have? Well, this is looking at any preterm birth, so not specifically late preterm birth. But I just wanted to show you the sort of spectrum of disorders that seem to be associated with prematurity when these babies get to adulthood. And you can see that in there is all-cause mortality as well, but a variety of conditions, many of them cardiovascular related and endocrine, principally diabetes. So looking now in detail at the late preterm, actually I think this is the late preterm group. Diabetes is something which is more prominent, more often seen in the late preterm group than the full-term reference group. And this follows that pattern. This is early term admissions because of endocrine and metabolic problems, usually diabetes. But again, up comes the overweight and obesity, not surprisingly, really, if we're thinking about cardiovascular conditions. And you can see that the rates of hospital admissions for both of these things are higher in the early term group than they are in the full term group. And this follow-up goes to 18 years. And the difference, if anything, seems to be getting more. Hypertension, too, seems to be highlighted as a problem that these children are more likely to develop. It's not seen in childhood up until 18 years, but when you get past 18 years, it does seem to be a problem then, and it rears its head once full adulthood is reached. There doesn't seem to be the same relationship with ischemic heart disease, although the Swedish data would suggest that it's a risk for the late preterm population, but other studies haven't found similar results. So we saw that all-cause mortality is raised in all preterm births. This is just taking stock of the early mortality for these children. And this is a Danish study, which is looking at a large number of singleton births. And you can see, again, this gradient of risk, this sloping line between 37 and 39 to 40 weeks gestation, indicating an increased risk of mortality. And that was seen even adjusting for complications in pregnancy. And it's seen in the early neonatal period, the first month of life, the first year of life, and indeed the first 5 years of life. This, again, is the Swedish data, which is looking at all-cause mortality to the age of 45 years. And I find this really quite worrying. The full-term group is the straight black line, and you can see that although the risk of mortality decreases from childhood, it's still raised compared with full-term birth in the late preterm and early term. So these babies, as they reach young and mid-adulthood, are more likely to die. And this is another study which is looking at Norway, Sweden, Denmark, and Finland, and showing a similar risk. You can see that the highest risk is with the 23 to 33 week group, but the 34 to 36 week group still has a significantly increased risk of all-cause mortality. What do they die from? Well, again, up comes diabetes and other cardiovascular disease as the greatest risk that's posed to these children, and indeed later in adulthood. So what do we do with all this? Well, I think the data that we have, such as it is, mainly from observational studies, shows quite clearly that late preterm and early term birth are associated with small but measurable differences in health and developmental outcomes when compared with full-term birth. I say small because the effect size is quite small. So these babies are not desperately disabled. They're not desperately ill. However, there are definitely adverse effects which appear to persist into adulthood, and indeed other adverse effects that may not even be identified until adulthood. The increased risk of mortality is seen in infancy, childhood, adolescence, and adulthood. So as far as we've measured, the birth at late preterm and early term gestation is associated with an increase in mortality at all ages. I think one thing that we have to bear in mind is that most of the data that we're looking at is quite old, and many of the studies that are being conducted now don't have the length of follow-up. But these, the studies that I've showed you about the adult data are dating back to the late 1990s of necessity, because we need to. It's great to see that the same Swedish data, which is just amazing, is now being analysed beyond the 1998 cohort, and Stefan is one of the people who's involved in that. So I look forward to seeing more. What's disappointing is that it seems to be showing a similar trend of this gradient of risk associated with gestational age. But the greatest risk across the lifespan, to me, seems to be from cardiovascular disease and metabolic syndrome. The respiratory adverse outcomes seem to attenuate with increasing age, though I think we have yet to see what happens in old age with the increased risk of sort of aging with it. But overwhelmingly, the effect is because of the large numbers of these individuals. So even if the effect on health, development, and education is modest, because it's such a large number, it's likely to exert a very significant burden on healthcare services, educational services, social services, and indeed families. So one last question. In your centre, do you routinely follow up babies that are born between 34 and 38 weeks? And by routinely, I mean, do all or nearly all of them get followed up? And this is a really interesting question for me, because in the UK, you have to be really, really sick as a neonate to get followed up at this gestation. You have to be really, really sick. So we don't routinely follow these babies up. So I'm surprised that the number of yeses is that high, actually, but I'm quite interested to see that. But most centres, it seems, do not routinely follow these babies up. So this is my last slide, and it's a series of questions, as you'll see, because I think the data we have for these more mature babies really raises more questions than it gives answers. I think the best way of preventing adverse outcomes is by preventing these births, and the question of whether these late preterm and early term births can be further reduced is an interesting one. I would not want to be an obstetrician making the decision whether to deliver a baby at 36 weeks or 38 weeks if the alternative was the likelihood of stillbirth. What we don't know is which babies are at greatest risk. And how we can target these babies, because we don't know who to target. Whether there are any interventions which we might be able to put in place, whether changes in our neonatal management might help. Should we be following up all our late preterm and early term babies? Can we follow up all these babies? Because there's a huge number of them. And if so, for how long? And I think an interesting question is, should adult physicians routinely be asking about a history of preterm or early term birth before early term birth when they are seeing their patients in the adult clinic? So hopefully there'll be some questions and some discussion, but thank you for listening.